this presentation, we will review the image analysis of the abdomen. We will review image analysis guidelines for the AP supine and upright, and we will review for the decubitus projection as well. We will also review common positioning errors, how to identify positioning errors, and ways to take corrective action. Image analysis guidelines for the supine AP abdomen projection states that the spinous processes should be aligned with the midline of the vertebral column with the pedicles at equal distances from them. Our iliac wings should be symmetric. The sacrum should be centered within the inlet of the pelvis and is aligned with the pubic symphysis. The long axis of the vertebral column should be centered on the projection. The fourth lumbar vertebra should be at the center of the exposure field. The 12th thoracic vertebra, the lateral body soft tissues, the iliac wings, and the pubic symphysis are all to be included within the exposure field. The diaphragm domes should be located superior to the 9th posterior rib. Here are those image analysis guidelines for your review. Next, we're going to review the image analysis guidelines for the AP abdomen upright projection. When conducting this projection, an arrow or a marker with beads or a word marker should be placed on the image indicating that the patient was in the upright position so that the radiologist is informed. Spinous processes should be aligned with the midline of the vertebral bodies with the pedicles at equal distances from them. Again, the iliac wings should be in symmetry. The sacrum should be centered within the pelvis inlet and aligned with the pubic symphysis. The long axis of the vertebral column will be centered on the projection. The third lumbar vertebra or the fourth, depending upon protocol, will be at the center of the exposure field. The 8th thoracic vertebra, lateral body soft tissue, and iliac wings are all to be included within the exposure field. The diaphragm domes should be located superior to the 9th posterior rib if the exposure is taken on full suspended expiration as indicated. Here are those image analysis guidelines for your review. So let's talk about abdomen rotation. When performing a supine or even an upright abdomen and there is rotation, this can result in distortion of the anatomic structures. Failing to position that mid-coronal plane with the IR decreases the visualization of fat lines that surround abdominal structures, such as the psoas muscles. When there's a shift in or rotation, this eliminates subject contrast, which it differentiates between the muscle and the fat when they're separated. This hinders the usefulness of the psoas major muscles as diagnostic indicators. So, how do we evaluate for rotation? You should evaluate the entire spine, because from the thoracic spine all the way down to the lumbar, upper lumbar to the sacrum and coccyx, we can shift our hips and still have the upper half of our spine in alignment. So you have to really look at the entire spine to ensure that there is no rotation. But to detect rotation on an AP abdomen projection, we should compare the distances of the pedicles to the spinous processes on each side, the widths of the iliac wings, and evaluate the centering of the sacrum within the inlet of the pelvis. If the distances from the pedicles to the spinous processes are greater on one side than the other, or an iliac wing seems to be more narrow than the other, or if the sacrum is positioned within the pelvic inlet closer to one side than the other, then there is some type of rotation. Once that is indicated and you have identified that there is rotation, we should repeat the image to ensure that we get a true AP projection by moving the midcoronal plane parallel with the IR. Please analyze this first practice analysis and then answer the question. So now let's analyze this image together. First, we're going to determine whether this is a supine or upright projection. Lucky for us, this radiographer did mark the image, and it is a supine projection. However, you do want to evaluate for any air fluid levels. From my experience, I can tell that there is no air fluid levels, but there is air within the abdomen and some fecal material. Next, we want to determine if there's any rotation. By looking at this image, the spinous processes, first, we're going to look at those, are aligned down the midline of the vertebral column. Next, you want to look at the iliac wings. One does look slightly, the right looks a little slightly more narrow than the left. I cannot see the alignment of the sacrum with the pubic symphysis, but it is close to being centered to the pubic symphysis. So the shift in the non-symmetry in the pelvic wings could be pathological. Would I send this image in? Well, yes, I would send this image in. However, we would need to take a repeat projection because the pubic symphysis was clipped for the supine projection. And if you recall, you must have pubic symphysis up to the diaphragm depending on protocol. And so therefore we need to repeat this. I wouldn't take a full projection. I would actually take a bladder shot. But for all intents and purposes of this analysis, because this was a male patient, their pelvis is a little bit more narrower than a female's because females is much wider. So in some cases you may need to actually center a little lower, about an inch inferior to the iliac crest to include that pubic symphysis. Moving on, please evaluate this next projection and answer the following question. Now, let's evaluate this image together. First, we're going to determine, again, whether this is an upright projection or a supine projection. You definitely want to evaluate for any air fluid levels. In this case, there may be one in the stomach there, but it's not as easily identifiable. So therefore, also look for your marker indicators. And so we have an upright arrow here, which indicates to us that this was an upright projection. Next, we want to look for whether there's any rotation. And so we're going to evaluate the symmetry of the iliac wings. You can evaluate the symmetry of the obturator foramen if they're visible. You can utilize the spinous processes in their position with down the midline of the vertebral column, as well as the position of the sacrum and coccyx in alignment with the pubic symphysis. And in this case, there is no rotation indicated. However, we need to evaluate, do we have all our anatomic structures required for this projection? And being that this is an upright projection, we do not have the diaphragmatic domes, okay? So therefore, we're going to need to take a repeat projection. That will have us recenter the central ray and the IR approximately 2 inches superior to the iliac crest to include those domes. Please evaluate this next practice analysis and answer the following question. So let's evaluate this abdomen upright projection together. In this projection, again, you want to determine whether this is upright or supine. There should be a marker indicator, or you want to look for your air fluid levels. In this case, this is an upright projection. The radiographer did their due diligence in marking the projection appropriately. Next, you want to look for rotation. We're going to look at the iliac wings, see if they are symmetric, which they are. This patient, we want to look at their spinous processes and their alignment down the midline of the vertebral column. And for the most, part, they are. However, there is a little bit of scoliosis here, so don't let that throw you off, because those spinous processes and the transverse processes there are still equidistant. Next, you can also look at the sacrum position within the pelvic inlet as well, which it looks like it's within acceptable limits. So there's no real rotation here. We also want to determine, do we have all the anatomic structures that we need for an upright projection? And in this case, we have most of the abdomen, okay? And we have the diaphragms. However, we got a lot of lung here. Two things, we could center a little lower and decrease some of that lung. But if you look at and count backwards, you'll see that the diaphragm is at the level of the 11th thoracic vertebra, which should indicate to you that the projection was taken on inspiration. Therefore, we need to repeat the image and take the exposure after the full expiration. Let's move on to the AP projection, left lateral decubitus projection. Image analysis guidelines for the abdomen AP lateral decubitus state that an arrow or a word marker should be placed on the image to indicate that the right side of the patient was positioned up and away from the imaging table. The spinous processes, again, should be aligned down the midline of the vertebral column with the pedicles at equal distance from them. Iliac wings should be in symmetry. The third lumbar or fourth lumbar vertebra should be centered at the center of the exposure field, dependent upon hospital protocol. The right hemodiaphragm, athoracic vertebra, right lateral body soft tissue, and iliac wings are to be included within the exposure field. The diaphragm domes are located superior to the ninth posterior rib when the patient takes the exposure is taken on full suspended expiration. Here are those image analysis guidelines for your review. I'm going to give you a few moments so that you can analyze this image and then answer the following question. So let's review this image analysis of the left lateral decubitus together. And looking at this image, it's a hot mess express. However, let's get into this. First, I want to look and see, do we have all our anatomic structures? In this case, we do have the diaphragm. We have a little bit too much diaphragm, so I do suggest some recentering here. Typically, most protocols require the pubic symphysis to the diaphragm, so this may require two projections, one lower abdomen, one upper abdomen. Or if you don't have to have pubic symphysis, then we should be centered around L3. Once you fix the central ray issue, we need to talk about whether or not there's rotation here. There's several key indicators here. We're looking for the spinous processes to be centered down the vertebral column, which they are not. You want to use your iliac wings. We barely see them at the bottom of this image, but I can see that the right iliac wing is foreshortened or more narrow than the left. Since this is a AP projection, that indicates to me that the right side is further away from the IR. The patient is more in a LPO projection. Also, you can utilize the contour of the ribs, the posterior ribs in this. When looking at the ribs, one side is foreshortened, which is the right, and the other side is elongated. That is away from the IR, which is the right, will foreshorten. Also, there is a lot of artifacts on here. These are snaps. It looks like they're snaps from EKG leads. Please remove them. If they're not attached to anything and you don't need those on there, they could be obscuring some type of pathology, and we don't want to do that. We want the radiologist to have all the information. So in order to correct this projection, you may need to recenter the central ray to a more appropriate location, whether that is at L3 or at the level of the iliac crests. And then rotate the right side back towards the IR so the mid-coronal plane is parallel with the IR. The textbook does suggest placing a pillow between the patient's knees for support so that they don't tend to lean forward or roll forward. Also, remove those artifacts. Again, it's important to not obscure any anatomy unnecessarily. This concludes our image analysis of the abdomen. If you have any questions, please feel free to stop me in clinical or email me. Thank you.